So guys, where are we now? We have already reviewed the anatomy and physiology of the neurological system. So now we can proceed and look at now the common tests and diagnostic workouts that are conducted for a patient with suspected neurological problem. Okay, we could do skull and spinal radiography, and this will reveal the size, the shape of the skull bones. We could also note the suture separation in infants. We could also see the fractures and bone defects, erosions, and calcification. Remember, spinal radiographs will identify fractures, dislocation, compression, curvatures, erosion, narrowed spine cord, and even degenerative processes. So as a nurse, you need to provide nursing support for the confused or the competitive patient or the ventilator dependent patient. You also need to maintain immobilization of the neck if a spinal fracture is suspected, and you have to remove any metal items from the client. So if the client has a thick or heavy hair, this should be also be documented. And in post-procedure intervention, you have to maintain immobilization until results are out. Okay, you always need to ensure that you check the client, right, about the possibility of pregnancy before any radiographic procedures. Okay, because some of these contrasts may have an effect on teratogenic effects on pregnancy for that case. Okay. The other test is computed tomography, the CT scan, guys. Sometimes it may be or may not require injection of a dye. So you have, and this test is important because it helps us detect intracranial bleeding and space occupying lesions, cerebral edema, infarctions, hydrocephalus, cerebral atrophy, and shifts of brain structures. Remember, you need an informed consent in any invasive procedure, especially those that are including a contrast, right? Okay. So you have to assess for allergies to iodine, contrast, or selfish in an iodine if the dye is used. Okay. Remember, we just want to take care so that we don't have acute kidney injuries for that case. And we have to assess renal function and verify contrast dose with the pharmacy. Instruct the client of the need to lie still and flat, and also instruct the client to hold their breath. You can also initiate the intravenous line with the appropriate gauge if prescribed, and remove objects from the head, e.g. the wigs, the barrels, the earrings, the hairpins, and assess for claustrophobia. Okay. Also inform the client of possible mechanical noises as the scanning occurs so that they can cooperate. You inform the client that they may be a hot or flash sensations and a metallic taste in the mouth when the dye is injected, right? So they have to be aware of this, right? Some clients may be given the dye even if they report an allergy, right? So in such a kind of category of patients, they may be treated with antihistamines or corticosteroids before the injection just to reduce the severity of the reactions. Also, you need to assess the need to withhold metformin, right? Remember, it should be 24 hours before the test or 48 hours after the test, okay? Especially if iodinated contrast is used for diagnostic procedure because of the risk of metformin-induced lactic acidosis. In the post-procedure intervention, you have to provide replacement for fluids because of the diuresis that is caused by the dye. And you also have to monitor for allergic reaction to the dye, especially for those patients who had an allergy to it. Also assess the dye injection site for bleeding or hematoma and monitor the extremity for color, warmth, and the presence of distal pulses. You could also have a test like lumbar puncture, especially if you suspect of meningitis, all right? So in pre-procedure, you have the patient will have to empty their bladder, okay? So we don't want accidental pricks, okay, and rupture of the bladder. And you have to help put the patient in lateral recumbent position. All right, guys, a link will be popping up on how to place a patient in this position. All right, you also need to assess with the collection and maintain a strict asepsis. All right. Okay, you have to position the patient flat. That's 1 hour just to increase at least the fluid, right, in our body. Okay, and also check the cerebrospinal fluid leakage. You could do the halo test here, right? You can do the halo test in this case, okay, where in case we have leakage, we will be having such representation, all right, or the spinal headache. If you look at the normal characteristics for the CSF, I don't. When you look at the cerebrospinal analysis, right? You collecting the CSF. You want to assess it for color, clarity, glucose level, protein, blood, white BC, and bacteria. So for a normal one, you find white cells could be around 0 to 5 cells, glucose 40 to 80 milligrams per deciliter, protein 16 to 45. So in post-procedure, you're supposed to assess the site for leakage of CSF. You could do the halo test, right? And also look at the signs of infection, right? So you have to do head elevation if you are using a water-based contrast, or a flat position if you are using an oil, right? If you're using an oil, that's what you can be able to do, right? So oil, flat, okay? Remember flat and fats. So fats, oil, flat, oil, all right? In that case, remember any changes could interfere with the imaging results, okay? If you try to interchange. In number 4, we have the cerebral angiography. So here you also need to assess for allergies, renal function, anticoagulation, hydration 2 days before, and also meal per oral 4 to 6 hours before the procedure. You could also do neuro assessment where you also mark the peripheral pulses, remove metal items from the hair, and you pre-medicate this patient. In post-procedure, you're going to monitor the vital signs, right, in the neurovascular also, status for in the affected extremities, bed rest for 12 hours, you elevate 15 to 30 degrees if prescribed, and you keep the body flat, all right? So you immobilize the limbs, you do ice compress. You also assess peripheral pulses and encourage fluid intake, right? Also watch out for any swelling and difficult in swallowing. Number 5 is electroencephalography, right? This is a test that will measure electrical activity in the brain using small metal discs that are attached to the scalp. So brain cells will communicate via electrical impulses and are active all the time, even during a sleep, right? So this activity shows up as wavy lines on the EEG recording, right? So you need to keep patient awake a night before just to induce the sleep, and you wash the hair, withhold stimulants, and allow breakfast. You have to pre-medicate the patient using sedatives. In the post procedure, you carry out seizure precautions and wash the client's hair and maintain safety for that case, right? Caloric testing is the next, and this one is testing for this test stimulates the acoustic nerve, and this by either delivering cold or warm water or air in the ear canal. So when the cold water or air will enter the ear, the inner ear will change the temperature and should cause some fast side to side eye movement or nystagmus within 20 to 30 seconds. Cranial nerves. We have talked of the 12 cranial nerves, for example, guys. So we could have several tests for this one, right? They could test smell by presenting normal common items to the patient, and you maybe request them to identify them. The number 2, you could do vision test where you see the vision acuity, right? And also look at now the muscle movement, okay, movement of the eye to look at the nose for number 4. Number 5, you're testing face sensations and mastication, the chewing part. And number 6, you're looking at abducting the eye, moving the eye away from the midline, right? That will at least help. While moving the eyes towards the midline is testing which nerve? Number 4, guys. All right? Okay, so the facial one, you're looking at the facial expression, making grimaces for that case, and also testing. While number 8, you're testing hearing using the Rhine-Weber whisper test. The number 9, you're looking at taste and the gag reflex. Also, the gag reflex is also very important in number 10, along with parasympathetic nervation. And then number 11, we are asking the patient to shrug the shoulders. Okay, and then we apply some force. Okay, if you are not able to hold it, then that will be this accessory nerve will be impaired for that case. Lastly, is about swallowing and speech, which will be testing the hypoglossal nerve. All right. So we have the GCS, right? The GCS, the Glasgow Coma Scale, okay, where we are testing eye movement, verbal response, and motor response, all right? Remember, eye movement, the maximum score is 4, verbal is 5, and motor is 6. That's why we have 456, totaling to 15. The lowest score someone can get is 3, right? Alright, but a score of less than 8 will indicate that this is coma, so this patient needs to be managed appropriately. Okay, remember in the eye movement, we could have spontaneous, or we could be responding to stimuli or to pain with a 2 or none, where you're giving 1, right? Verbal response, it could be range from being voiceless to being having an elegant speech. Okay, where you get a maximum of 5. That means this guy is oriented to place, person, and time. A confused patient or disoriented will be scored 4, while those that are going to utter inappropriate words are going to be scored 3, and those will obscure or incoherent sounds, producing those sounds, will be awarded 2. Lastly will be 6, where it will range from having able to obey the commands, that will be graded as number 6, up to the last one, which is number 1. Of importance is to know the difference between decorticate and decelerate, right? So decelerate will be given a score of 2, while decorticate a score of 3. Okay, so decelerate, this is a person whose limbs will extend away from their head. Okay, so thus they'll be decelerating. While decorticate, this is a person whose elbows will bend and falls with arms towards their chest. Okay, so you'll have decorticate positioning. Guys, remember decorticate position will be given will be awarded 3, while decelerate will be awarded 2. Okay, okay, so decelerate is the worst symptom ever. All right. Okay, guys. Next, we have meningeal irritations. And in meningeal irritation, we could have signs like the keg sign and the Brudisky sign. Okay, the Brudisky sign. So for the keg sign, we have the inability to straighten the leg completely when it is fully flexed at the hip and the knee. Okay, while the Brudisky sign, we shall be having involuntary flexion of the hip and the knee when the neck is passively flexed. Okay, you try to flex the neck, then we have involuntary move flexion, okay, of the hip and the knee. Okay, while the keg sign is we have inability to straighten. You can't straighten the leg completely, right, when it's fully flexed at this knee and the hip. Okay, in children, we could see symptoms like irritability, knuckle rigidity. Okay. In other cases, you could have severe and relenting headaches. All right. In adults, we have generalized muscle aches and pain, nausea and vomiting, fever and chills, tachycardia, photophobia, nystagmus, and abnormal pupil reaction and eye movement for that case. Okay. Okay, so guys, that wraps the end of the diagnostic test used in neurological system diagnosis. Okay. Okay, now we can look at some of the disorders, guys. We could have unconscious patients, increased intracranial pressure, hyperthermia, patients with CVA, stroke, aneurysm, dementia, hyperthermia, Parkinsonism, multiple sclerosis, myasthenia gravis, and meningitis, guys. So we can start with which one? Unconscious patients. These are unarousable, okay, could be primitive or demonstrate no response to painful stimuli with altered respiration and decreased cranial nerve and reflex activity for that case, okay. So they experience diminished alertness, decreased self-awareness, and impaired responsiveness to external stimuli. For such a patient as a nurse, you have to maintain a patterned airway by positioning the patient appropriately and sanctioning secretions where possible if needed, right? You have to monitor for the vital signs regularly and especially respiratory rate, oxygen saturation, and intervene promptly. You have to protect the patient from skin breakdown, right? This pressure injuries. Guys, a link on pressure injuries will be popping up. You can see how to grade them and how to manage the different degrees, all right? Okay, guys, number 2 is increased ICP, increased intracranial pressure. Normally, the normal pressure will range, intracranial pressure will range between 5 to 15 millimeters of mercury. If you have a pressure greater than 20, this will need treatment. The earliest sign for somebody with increased ICP is mental status change or altered level of consciousness. And this could be caused by injury, to especially the head injury or trauma, and then increase in CSF production, right? Or the encephalitis, or another cause could be hemorrhage, hematoma, tumor, hydrocephalus. All of them will lead to increased ICP. Remember, it's causing disturbance within the three components, okay? The blood, brain, and the CSF, right? Okay, guys, for your information, you just need to know that the main symptoms of ICP, increased ICP, is actually a complete opposite of the symptoms in shock, right? Okay, so in shock, we expect to have decreased BP, increased pulse, and respiration as they try to compensate for that. But in ICP, we're going to have increased BP and reduced pulse and reduced respiration, what we commonly refer to as the Cushing triad, right? The Cushing triad for that case, okay? So the cause of this increased ICP can be explained using the Monro-Kelly hypothesis, where he says that if the volume of one of these structures, could it be the brain, the cerebrospinal fluid, or the blood is affected, the others will have to decrease their volume to elevate the pressure. Okay, so when there is an increase in ICP, the body can temporarily compensate it by shifting either CSF to other areas of the brain or spinal cord, or altering blood flow going to the brain through vasoconstriction, okay? But if the pressure is continuous, it is unable now to compensate for such, okay? For that case. Remember, daily someone is able to produce around 600 mils of the CSF, okay? Daily. And we had already said they are produced by the choroid plexus, okay? Starting from the lateral to the third to the fourth until they are reabsorbed at the subarachnoid space, okay? Okay, guys, that is so good of you guys. We can be able to proceed for this one, okay? So here we also need to look at the CPP, which is the cerebral perfusion pressure. And the normal one normally ranges between 60 to 100 millimeters of mercury. So when the CCF falls too low, the brain is not perfused properly, sometimes, so the brain cells will start to die. Okay, so if a patient's mean arterial pressure starts to fall to the patient's ICP, then cerebral perfusion pressure will drop. So therefore, maintaining a sufficient map is essential. So one needs to know how to get the map, of which the map now, of course we take the map, we take the diastolic, you add it to twice the systolic systolic, the systolic added to twice diastolic, then divide everything by 3. Okay, but our focus here is CPP, cerebral perfusion pressure. You normally get it by taking MAP, you subtract the ICP. So if you know the following, like for example, if a patient has a BP of 90/42 and ICP 19, what will be the cerebral perfusion pressure? First of all, we calculate MAP. So MAP, we take twice the diastolic, so it is 2 times 42 plus 90. Okay, divide everything by 2. Okay, divide everything by 2. By 3, I mean, you get 58. Okay, 42 times 2, get 84. 84 added to 90. 90 is our systolic, get 174. Everything divided by 3, get our map is 58, right? Our map is 58. And they had given us our ICP as 19. So to get CPP, you simply take 58 minus 19, you get 39. And this is very low. Remember, the normal range should be between what? 60 to 100. So this means that there is impaired brain perfusion for that case. Okay. So what normally causes increased ICP within the skull? We have already mentioned. It could be an injury. It could be due to increased cerebrospinal fluid. It could be due to hemorrhage, hematoma, hydrocephalus, tumor, or encephalitis for that case. Okay. And what happens with this increased ICP? When you have increased ICP, you have said we have limited cerebral blood flow due to decreased cerebral perfusion from the building pressure in the brain. So the brain cell will be getting squeezed, and this leads to ischemia. So all of these can lead to swelling and edema, which can eventually, if not treated, lead to herniation or displacement of the brain. And the displacement of the brain can compress important areas in the brain, okay, specifically the medulla and the vagus nerve. So when CPP, cerebral perfusion pressure, falls too low, the body tries to increase systolic pressure in order to make more blood go to the brain, and this makes things worse. All right. So during this time, the arteries will start to dilate because of the retention of the carbon dioxide, and this causes more blood to flow to the brain, and this will compress veins and limit blood to the heart. So hence, this will lead to swelling and even more ICP, because we have again destabilized the 3 components. So here in this case, blood is the cause again. Okay. So as all this progresses, the patient's signs and symptoms will start to become worse. Therefore, it is essential to know that the earliest signs and symptoms of increased ICP is mental status changes. Okay? All right. In terms of signs and symptoms, we could say mind is crushed, and that's the mnemonic, where we have already talked and said that mental status changes is the earliest sign, right? Remember, and this one is very common in exams. You have to know it. So the patient will appear restless, confused, will have problems performing normal movements and responding to questions. The next one, we have irregular breathing. And why is irregular breathing coming up? We have slowdown of respiration, and which becomes irregular. We normally describe them as chain stocks. So the patient will hyperventilate, then have an apnea cyclic, and this is normally a late sign. Okay. Nerve changes to optic and oculomotor nerve, where patient will present with double vision, swelling of the optic nerve. They'll experience the papilledema, papillary changes, that is decreased or increased or an equal size. Abnormal doll's eyes, where we have this oculocephalic reflex. In unconscious patient, we could have open eyes and move the head from side to side. All right, so that's how they behave. And if eyes don't move in the opposite direction but stay fixed, that means this will be a bad sign. It will indicate that there is brain stem damage, right? So we have the decelerate and decorticate, right? All right. So decorticate, this is flexure positioning, right? Flexure positioning. On a GCS, we'll score this as 3, but decelerate will be scored less. That is 2. Okay, that is 2. So in decorticate, we are bringing upper extremities to the core of the body, to the middle of the body. So we have adduction and flexion, okay? Legs rotated internally, okay? And feet flexed. While on the other hand, now the celebrate, we have extension of the upper extremities from the body, okay? It's the worst of the two, right? If you look at that. Remember, all is in the celebrate and you just think of extension, all right? Extension for that case. We could also have reflexive positive Babinski reflex or unconscious, which is of course late. Our patient could present with seizures, headache, vomiting, deterioration in motor function for that case. Okay, as soon as you have to focus on preventing further increase in ICP and monitoring, of course, of the ICP if monitoring device is inserted. Remember to position your head of the bed 30 to 40 degrees as this will help blood return to the heart and will have proper alignment of the head. So no flexion of the neck because if you flex, you're going to decrease the venous return. Or hips, if you do, it will increase intra-abdominal pressure and this again will interfere with the condition. Okay, so watch moving around. All right, you have to move around in the bed. All right. Next is the respiratory. You prevent hypoxia and hypercapnia. So remember when blood oxygen uh, levels drops or carbon dioxide increase, vasodilation normally occurs, and this increases the intracranial pressure. You also need to monitor the blood gases and the oxygen level, so you suctioning as needed only, no longer than 15 seconds, right? Because if you do that, can also increase the ICP. Remember to hyperoxygenate before and after suction, right? Motor mechanical ventilation. You have to keep the partial pressure of carbon dioxide low. That is between 30 to 45. Why? Because carbon dioxide is going to cause vasoconstriction, and this vasoconstriction will help decrease ICP by decreasing blood flow. Okay, so you keep the PEEP low and increase the intrathoracic pressure, right? Okay, keeping intrathoracic pressure, it means you're going to cause impaired venous return to the upper body, so at least it will be retained in the lower limbs. Okay, we have elevated temperature. You can prevent this. You have to monitor the temperature. If the patient is unconscious, okay, you can take the best is to take tympanic, temporal or rectal, not orally or axillary for that case, because there is a risk for hyperthermia. So patient may have damage to the hypothalamus, infection, dehydration. So high temperature increases ICP and cerebral blood flow and metabolic needs of the patients. So can you give antipyretics? You can also give antipyretics as per the order. Remove extra blankets, decrease room temperature, cool baths, prevent shivering, right? Because if you shiver, this will increase metabolic needs and consequently the ICP also will be increased. Okay, remember to do the neuro checks and do the treatment with the barbiturates because barbiturates normally help decrease brain metabolism and BP, which in turn decreases ICP. And we can also do edema management. Okay, dehydrating the brain must be done carefully, watching the blood pressure and the renal function. We could use the mannitol. It's a concentrated type of sugar and one of the diuretics. Guys, a link will be popping up on the 5 different types of diuretics. Okay? All right. So hyperthermia is the other disorder and you find that this is classified so when the patient presents with a temperature of more than 40.0 degrees Celsius. Okay, it increases cerebral metabolism, hyperthermia, and it also increases the risk of hypoxia. Causes could be infection, heat, stroke, exposure to high environmental temperatures, dysfunction of the thermoregulatory center. So assessment, you have to do the temperature higher. A patient will be presenting with temperature higher than 40.6 degrees, 40.6 degrees Celsius, or shivering, or nausea and vomiting. So as a nurse, you have to keep a patterned airway, you have to initiate seizure precautions and monitor input and output, assess the skin and mucus for signs of dehydration, monitor for lungs sounds along with these dysrhythmias, peripheral pulses for systemic blood flow, and also inducing pneumothermia with fluids, cold baths, fans, or hypothermia blankets. Okay? Okay, guys. The next condition is CVA. This is stroke, and this is a condition that develops when the blood-rich oxygen cannot reach the brain cells. And it could be a blockage, due to blockage, or bleeding, and this causes the brain cells to die. So mostly we normally have two types of the CVA. It could be ischemic or hemorrhagic. All right. So ischemic is the most common one, and this is due to a blood clot within a blood vessels or stenosis of an artery that feeds the brain tissue. So this limits the blood that can reach the brain cells, and this type could be due to either embolism, thrombosis, for that case. On the other hand, hemorrhagic normally occurs when there is bleeding in the brain due to a break in the blood vessels. Therefore, no blood vessels will perfuse, no blood will perfuse to the brain cells. In addition, this can lead to excessive bleeding from leakage of the blood in the brain, and cause could be a rupture of a brain aneurysm, uncontrolled hypertension, or an aging population for that case, the old age. Okay. The third one, which is a mini stroke, is what we refer to as the TIA, transient ischemic attack. It occurs where signs and symptoms of a stroke occur but last only a few minutes or hours and then resolves. This could be a warning sign that an impending stroke may occur. So if it occurs, the patient needs to seek treatment for that case, okay, for the mean stroke. So remember that brain cells are very sensitive, and within 5 minutes these cells will start to become damaged, and the damage can become irreversible. So we have to act in the shortest time possible. So strokes, they tend to affect one side of the body, so you need to be familiar with the functions of the right and left side of the brain. All right. Okay. We have already looked at the cerebrum, and again, we're going to remind ourselves of this part. Remember, a patient could either be having right-sided or left-sided challenges. And the right side of the brain is the creative side of the brain, while the left one is the logical side of the brain. So the right side function includes things like attention, controlling our attention span, showing emotions, ability to solve everyday problems by making decisions and plans, and reasoning, like understanding jokes, reading in between the lines, right? So someone who is not able to understand the jokes, okay, and reading between the two just to know this is a joke, this is not, could be having a problem with the right-sided brain. Okay, making judgment, music, memory, music, awareness, control of the left side of the body. And if the patient has a right side brain damage, what do you think will happen? The patient is going to have problems with left-sided weakness because right side controls the left side. The patient is going to have impaired creativity, music, confused, cannot recognize faces or persons, loss of depth perception, trouble staying on topic, because of the attention span here, guys, can't see things on the left side. A right-sided brain, they normally have the left side neglect. Okay, all right. So they tend to ignore the left side of the body, and this predisposes them to so many injuries. Right? They can't maintain proper grooming, emotionally not going to think things through, so very impulsive. They have a poor ability to make decisions and assessing spatial qualities. They also have they deny about their limitations. They are not aware of their limitation. Okay, so not able to read nonverbal language. Okay, and have very short attention span. On the left side, guys, left side functions are involved in logical things like speaking, writing, reading, math skills, analyzing information, planning, okay? Planning for that case, okay? So if a patient has a left side brain, how will they appear? Remember, the left side control the right side, okay? So if you have a problem with the left brain, right, left side brain, you're going to present with right side hemiplegia, right? And now these other functions can be affected, right? Like aphasia, you'll have trouble formulating words, okay? Problem with the Wernicke's area and comprehending them, okay? Compared to the patients of the left-sided problems, okay, left side of the brain, the left one, the left-sided the left side brain damage patients are aware of their limits. Okay, the right are not aware. Okay, they deny it, very impulsive. The left one, they know. And this, first of all, has some disadvantage, guys. These patients tend to experience depression, anger, and frustrations about this. Okay? They also have trouble understanding written text because left side controls speaking, writing, and reading, right? So they can't write, so they have agraphia. They can't calculate, or they don't have the math skills. Their memory is intact, okay? So they have issues with seeing on the right side, right? And they are aware of the same. Okay? Okay, guys, so we can have now the other parts of the two in terms of risks. So we are saying that these risk factors, they should be able to be divided into modifiable and non-modifiable. So modifiable, these are things a person can change, and non-modifiable are things a person can't change. Okay, so we could use the stroke happen as a mnemonic to remind us all the risk factors, starting with smoking, use of blood thinners, the thrombolytics, the rhythm changes, AFib and flutter, oral contraceptive, family history, excessive weight, senior citizen or age citizen, hypertension, atherosclerosis, physical inactivity. If you have a transient ischemic attack, you've had it, or elevated blood sugars, aneurysm in the brain, this gives places you at increased risk for that, right? So in terms of signs and symptoms for stroke, it happens suddenly, so you need to act fast as the nurse to help save the brain. Remember, within how many minutes? 5 minutes. Okay, you call a rapid response, especially if in your US, so that you can receive appropriate treatment. Right? All right. So the exact time the signs and symptoms appear, you have to note it down, and this is very important for stroke treatment. Right? So we normally use the act fast, right? The act fast mnemonic. We have the National Stroke Association has recommended the use of this mnemonic because this will help us assess signs and symptoms for quickly. So the patient can also have the following as well. They could also present with bowel and bladder incontinence and retention, along with F for drooling or an even smile, arm numbness, weakness, drifting, that is raising. So you need to tell the patient to try and raise both arms. So we could see drifting. Speech, they can't repeat a phrase. They could have a slurred speech. And time is very important for you to note at what time did the symptoms start appearing for that case. All right. So we could have aphasia because of stroke. These are unable to speak, so they are not able to comprehend, so they are not producing it sometimes. Okay, we could have receptive aphasia. This is receptive aphasia. They are unable to comprehend the speech, and this could be a problem with the Wernicke's area. All right, or they are not able to, or for this second part, the patient is able to comprehend the speech, yes, but they can't respond back with correct words. So in this case, we said it is expressive aphasia, okay? Expressive aphasia. That is how someone has a problem with the Broca's area, okay? We could also have mixed aphasia where this combination of the two, Wernicke's and the Broca's area all are damaged, or the global aphasia where there is complete inability to understand speech and produce it, okay? We also have another abnormality, the dysarthria. These are unable to hear speech clearly due to weak muscles. Okay, hard to understand the patient's speech, and the speech also may be slurred, right? So we are unable to hear the speech clearly due to weak muscles. Apraxia, they can't perform voluntary movements like winking. They can't wink. They can't move the arm to scratch an itch even. The muscle are functional. The function is normal, so they can't do it, right? Agraphia is loss of the ability to write for that case, okay? So this is a stroke case. Alexia, this is loss of ability to read. They don't understand or they recognize the words. Agnosia, this is they don't understand sensation or recognize known objects or people, okay? Especially the right-sided people, right-sided brain damage. Dysphagia, we have issues swallowing because of weak muscles, or hemianopia, this is limited vision in half of the vision field, right, for that case. So next we have the hemiparesis. This is weakness of one side of the body, right? If you could be left side or right side. How it's diagnosed, we have the CT and the MRI, right? For that case. So medication for ischemic strokes, we could have a tissue plasminogen activator, especially for these ischemic strokes, not hemorrhagic, all right? So this tissue plasminogen activator normally dissolves the clot within the blood vessels by activating the protein that causes fibrolysis. And this drug, it must be given within 3 hours from the onset of stroke symptoms, okay? It can also be given 3 to 4 or 4.5 hours after the onset if the criteria is met. So to receive this tissue plasminogen activator, the patient should have at least a CT scan of the head that is negative hemorrhagic. The labs should be within the normal limits, especially the glucose, the ENR, and the platelets. Blood pressure needs to be controlled, so the systolic blood pressure needs to be below 185, while the diastolic should be below 110. Glucose should be controlled because it increases risk for hemorrhage, and it should not be receiving heparin or any other coagulants for that case. Your role is to monitor for bleeding, neurochecks around the clock, BP medication if needed for hypertension, all right, for that case. Remember to turn every 2 hours with proper alignment and watch for increased ICP, okay? Okay, so in assessing the stroke, we normally use the NHIS stroke scale where we have 11 assessments are scored, and the score ranges from 0 to 42. So 0, there is no stroke symptoms, but now for 21 to 42, this represents severe symptoms for that case. Okay? Intervention for aphasia, you have to make sure that communication is key. just because the patient can't communicate doesn't mean that they have a mental deficit. Okay, so get it, know how to communicate with your client. Okay, the problem in this case, they just can't get out, and it just takes time for them to do it. Okay, so the nursing role is to try and help bridge the gap between and make it less frustrating for the patient. For the receptive aphasia, the ones with a problem in the Wernicke's area, okay, they can't comprehend. They can't comprehend. You have to use short phrases, use gestures or point while giving a command. And you must be patient not to expect a fast response and remove most of these distractions. For the expressive, the one that can comprehend but can't respond back, okay, those with the problems with the Broca's area, you have to be patient with them and let them speak and be direct and simple when speaking and asking questions and give them options. Is it A or B? All right, so that they can easily pick A or pick B, okay. Communication could be through via an eraser board, okay, so where you can be able to write and have it, okay. Okay, so these patients may need thickened fluids and mechanical soft foods, and assist with eating and monitor for poaching of the food. You have, because the poaching will increase the risk for aspiration. So remember to ask the patient to tuck in the chin to their chest, especially when they are swallowing, to reduce the risk for choking. Right? Also about safety, all right, especially those with right side brain damage, they tend to forget about the left side, okay, and this is a risk for injury because the patient ignores the affected side. Okay, so you have to remind the patient to use and touch both sides of the body. Okay, make sure they must make a conscious effort to do so, right? Educate the patient about the importance of turning the head side by side to prevent injuring uh, the other part. Okay, okay, guys. So we have the spinal cord injury, right? Spinal cord injury. So this can lead to loss of motor functions, sensation, reflex activity, bowel, and complication. You have respiratory failure, autonomic dysreflexia, spinal shock, and further cord damage and death. Commonly, you have affected parts could be the cervical part, the lumbar, thoracic, and we have the spinal cord injury or the autonomic dysreflexia. So you have to assess the respiratory status, look at the sensory and motor paralysis below the injury, and look for reflexes. Okay, we could have low of reflexes, loss of bladder and control, presence of sweat, and this is not on the paralyzed areas. Tetraplegia, paraplegia for that case. Okay, so we have cervical injuries, that is C1 to C2, they are fatal. C4 is a major innervation to the brain, to the diaphragm, so it controls breathing for that case. And the C5 to C8 may involve the shoulders and decrease the respiratory reserve. Thoracic level injuries, we have loss of movement of the chest, the trunk, the bowel, the bladder, the legs. We could have leg paralysis may occur. Autonomic dysreflexia could be injuries above the T6. Right? Lumbar and sacral region, we could have absent motor and sensories of lower extremities. S1 to S3, patient could have neurological bladder problems. Above S2 could have the patient could be unable to ejaculate, while S2 to S4 we could have problem with erections and ejaculation. So you have to always suspect spinal cord injury when trauma occurs until this one is ruled out for that case. So here you need to assess the respiratory pattern, prevent head flexion, rotation and extension, maintain body in extended position, and in case of movement, you roll the patient, right? So no part of the body should be twisted or turned not allowed to sit, all right, for this patient. Cervical fracture in the ED should be placed immediately in the skeletal traction, right? Okay. So for the respiratory, you could assess respiratory, especially for C4 injuries, right? And monitor APGs, maintain mechanical ventilation, deep breathing or incentive spirometry, and you ruled out signs of infection like the pneumonia. Okay, so in this case, you're going to use the incentive spirometry, right? Spirometry. This will help people to take slow deep breaths, and it's like an exercise equipment for the lungs just to keep them strong and working well. For the cardiovascular, you could perform the Hoban sign, okay, the calf pain at the dorsiflexion of the knee, of the foot. So it is thought to be associated with the presence of thrombosis for that case. For the neurological system, you assess the neural status and you immobilize the client and also assess pain, initiate measures, and monitor complication of immobility for that case. For the gastrointestinal system, you assess distension and hemorrhage and monitor bowel sounds and paralytic ileus, prevent bowel retention and bowel control programs, and have adequate nutrition and high fiber diet for that case. So we have the spinal shock injury, all right? The spinal shock injury for that case.